Good morning, ladies and gentlemen. I am joining you again after a brief break in the continuity of the lecture program. So today's lecture is on congenital nevi. Let's proceed with the lecture. A few words about congenital nevi and the principles underlying the observable phenotypes of congenital nevi. The congenital nevi are ultimately caused by somatic mutations. So remember that it is somatic mutations. Only some part of the skin is affected. The rest of the skin appear entirely normal. So it is never a diffuse disease. This is a dermatological phenotypic correlation of genotypic mosaicism. Usually the genetics is mosaic. That is, there are different gene types which are present in congenital nevi. And this mosaicism is defined as presence of two or more genetically distinct population of cells within an individual that are derived from a single zygote. Technically, any individual with a small congenital nevus is a mosaic. Remember this also. The phenotype will largely be dictated by the normal function of the gene during development. The extent and or the number of lesions is an important, although not an absolute guide to the possibility of non-dermatological associations. Usually, the non-dermatological associations are more if the number of lesions are more. The cell type affected by the mutation is, of course, central to the clinical phenotype. That is, whether it is the epidermis or it is the melanocytes or collagen or connective tissue element, this is the main cell type which is affected by the mutation. So, classification of congenital nevi. On the basis of clinical phenotype, the congenital nevi may be classified as the congenital epidermal nevi, congenital pigment cell nevi, and the congenital connective tissue nevi. So, there are three types of congenital nevi on the phenotypic appearances. The nevi which are originating from the epidermal elements, from the pigment cell elements, and from the connective tissue. These can each be divided into lesions with cutaneous involvement only, which can be single or multiple lesion, and lesions which are syndromic. That is, they are association of cutaneous involvement with non-cutaneous features. Any of the above three lesions can be cutaneous only and can be syndromic. The histological classification. This is further subclassified based on the predominant cell type seen on histology. Number one is the keratinocytic nevi, in which the main histology is proliferation of keratinocytes. Sebaceous nevi, the main histology is presence of proliferation of sebaceous glands. Follicular nevi, the main histology is that of presence of multiple hair follicles. Then acrine or apocrine nevi, the main histology is that of presence of multiple acrine glands. Then about the congenital pigmented nevi. So the congenital pigmented nevi are mainly derived from the pigment cells and are subclassified on the basis of histology of pigmented cells. That is, they may be a melanocytic nevus, they may be blue nevus, Spitz nevus, or nevus spilus. So these are different categories of the pigment cells which determine the type of nevus. Connective tissue nevi. Among the connective tissue nevi, the nevi can be derived from collagen and hence called as collagen nevi, can be derived from elastic tissue and called as elastic tissue nevi, can be derived from the mucinous material and called as the mucinous nevi, and can be derived from the fat and called as the fat nevi. As far as the congenital epidermal nevi are concerned, they are sometimes divided into an organoid or non-organoid. The organoid congenital epidermal nevi means that they have an adnexal origin, that is, either a sebaceous gland, sweat gland, or hair follicle. And non-organoid is simply keratinocytic. So, Among the congenital epidermal nevi, they are either non-organoid, which are derived only from the keratinocyte. The example is the verrucous epidermal nevus, or it can be organoid, in which they are derived from the sebaceous gland, hair follicles, or sweat glands, like the sebaceous nevus or the hair follicular nevus or eccrine nevi. Congenital epidermal nevi, or also known as, which will be abbreviated as CEN, are benign nevi of epidermal components that are present at birth or appearing in first few years of life. This encompasses a wide range of clinical and histological phenotypes, which can occur as isolated cutaneous lesions or in association with extracutaneous features as a part of diverse syndromes. In many cases, histopathology is required to make an accurate diagnosis, and full phenotype may not be apparent for several years because it takes time for the full phenotype to develop. Congenital epidermal nevi with extracutaneous features are known as congenital epidermal nevi syndromes, which are association of congenital epidermal nevi with extracutaneous features with a predilection of neurological, ophthalmological, skeletal, and endocrine abnormalities. So four main systems are involved when the epidermal nevi change into epidermal nevi syndromes, either neurological involvement, ophthalmological involvement, skeletal, or endocrine abnormalities. The commonest congenital epidermal nevi are the sebaceous nevi, which have a prevalence of 1 to 3 in 1,000 general population. The Proteus syndrome occurring in 1 million birth. So it is so rare as compared to sebaceous nevus. As far as the mutations is concerned, although this is difficult to remember, but I have just included this slide to mention that all the epidermal nevi are having some basis of mutation, rather most of them. By definition, congenital epidermal nevi are usually present at birth, although some types can appear in first few years of life. Although genes are present, but appear at first few years of life. Most congenital epidermal nevi are caused by single post-zygotic mutation that lead to an epidermal mosaicism. The mutation is post-zygotic, after the formation of zygote. Keratinocytic congenital epidermal nevi can be caused by mutation of fibroblast growth factor receptor 3, FGFR3. And in the CLOVES syndrome, it is PIK3CA. In Proteus syndrome, it is AKT1. And in epidermolytic nevus subtype, it is KRT1 and KRT10. Sebaceous nevi are caused by mutation of HRAS or KRAS. Follicular nevi result from mutation of FGFR2. Porokeratotic eccrine nevi due to mutation of GJB2. In child syndrome, this mechanism is X inactivation. One of the X chromosome is inactivated. In Cowden syndrome, the mechanism is superimposed somatic loss of heterozygosity in normal allele of PTN gene. Pathology of congenital epidermal nevi. Epidermal nevi are localized hematomatous processes that are characterized by hyperkeratosis, thickened epidermis, and papillomatosis. The lesions and papillomatosis. You can see the verrucous epidermal nevi. There is hyperkeratosis and epidermal hyperplasia. Papillomatosis is also visible. The tenting of epidermis upside is called as papillomatosis. The lesions are classified histologically based on predominant epidermal component, either keratinocytic or organoid like sebaceous, follicular, eccrine epithelium, and whether there is an inflammatory component or not. If inflammatory component is prominent, the lesions are called as the inflammatory linear verrucous epidermal nevus or ILVEN. And usually there is marked inflammatory component, which has some psoriasiform appearance with dense associated superficial dermal inflammatory infiltrate. Following puberty, these all lesions become more prominent. So here, this is a difference between the normal epidermal nevus with ILVEN or inflammatory linear verrucous epidermal nevus. You can see lots of lymphocytes, and in addition to lymphocytes, other cells like neutrophils and macrophages are also present. So once the inflammation is prominent, then the verrucous epidermal nevus will become inflammatory linear verrucous epidermal nevus or ILVEN. This histology is that of sebaceous nevus. You can see lots of sebaceous glands which are associated with this nevoid proliferation. Then congenital epidermal nevi clinical features. Single congenital epidermal nevus lesion can be either round or linear, but larger or multiple lesions in Blaschkoid distribution is also seen. The only exception to this are the recently described nevi of PENS, papillary epidermal nevus with skyline basal cell layer, which are multiple but round or ovoid. The epidermal nevi are by their nature very superficial and are therefore raised and have appearance of being stuck onto the surface of the skin rather than intrinsic to the skin. Their surface characteristically depends on the cell type they predominate, whether sebaceous or keratinocytic. Then keratinocytic nevi. Mostly they are pale brown with soft velvety feel to brown or red verrucous or hyperkeratotic, and can have prominent inflammatory component, which clinically shows as erythema, crusting, scaling. So ILVEN commonly appears in first few years of life rather than at birth, and is spread gradually until stabilizes in classical Blaschko linear distribution. So the ILVEN does not manifest at the birth and usually manifest later. It is characterized clinically by inflamed and hyperkeratotic skin, which is pruritic. So a symptom is mainly pruritus. Clinically and histologically, there is a significant overlap between ILVEN and psoriasis. So sometimes it is difficult to diagnose or differentiate ILVEN with psoriasis or linear psoriasis in young children. This is a typical appearance of a verrucous epidermal nevus, which you can see in a classical Blaschkoid distribution. Sebaceous nevus have a greasy feel and appear, and is yellowish or pink, but sometimes can be deeply pigmented. Then the follicular nevi, like nevus comedonicus or acne nevus, are skin-colored with high density of multiple comedo-like lesions. Then congenital eccrine or apocrine nevi are recognized by the localized hyperhidrosis with porokeratotic variants of eccrine nevus exhibiting the classical signs of porokeratosis. Although syringocyst adenoma papilliferum is thought to be an hematoma of eccrine or apocrine gland, it frequently arises in clinical practice from a sebaceous nevus. So we see this follicular nevi, the comedonal nevi, then the porokeratotic variants of the eccrine nevi, and syringocyst adenoma papilliferum. They are all the organoid subtypes of congenital epidermal nevi. This is a sebaceous nevus. The most common site is scalp, but can be seen on the face. The lesion is present almost from the birth and has a yellowish, orangish yellow hue or appear and is have a greasy feel. HRAS mosaicism. There is a syndrome which is called as Schimmel-Penning Fluorescein Mim syndrome and Phakomatosis pigmentokeratotica, which are viewed as phenotypes within a spectrum of the same mosaic HRASopathy. The clinical feature of this mosaicism is linear sebaceous epidermal nevi with or without the following. So the main appearance is linear sebaceous epidermal nevi with areas of epidermal nevus or nevus spilus or capillary macular pigmentation with neurological ocular skeletal involvement and hypophosphatemia leading to rickets. This is an endocrine abnormality. Proteus syndrome. The Proteus syndrome is a mosaic disorder of overgrowth, and diagnostic criteria are well established. And cutaneous lesions include, number 1, keratotic epidermal nevi, connective tissue nevi, lipomas, vascular nevi, and patchy hypoplasia or dermal hypoplasia. So, Proteus syndrome include almost all type of congenital nevi, that is keratotic nevi, the connective tissue nevi, and the pigmented and vascular nevi. The number of skin lesions correlate to some degree with severity of phenotype in an affected individual and can progress over time. The Proteus syndrome is defined by diagnostic criteria and caused by a somatic mutation, somatic mosaicism for mutation in AKT1 gene. This is my real patient of Proteus syndrome. You can see lots of lipomas, comedones, and acne and cystic-like lesions. This side is almost clear, this side is involved. And you can see the background vascular nevus with gross hyperplasia. And if you compare the feet, this foot is grossly thickened, both in size, thickened in girth and increase in size. CLOVES syndrome. This acronym is a description of the association of congenital lipomatous overgrowth, then vascular malformations, epidermal nevi, and skeletal abnormality. This overgrowth syndrome can also be associated with neurological abnormalities. So the CLOVES syndrome is very similar to Proteus syndrome. Despite sharing many similar clinical features, it can be distinguished both clinically and genotypically from the Proteus syndrome. And it is caused by somatic mutation in PIK3CA gene. The PENS syndrome. The PENS syndrome is characterized by multiple, the multiple is important, round or ovoid, papular, whitish yellow, keratotic lesions, usually 0.1, that is 1 millimeter to 15 millimeter in diameter, present at birth or develop shortly after, and have a characteristic histological appearance of a skyline basal cell layer. Most of the cases described have a mild neurodevelopmental delay and or epilepsy. And the genetic basis of PENS syndrome is unknown till now. Then child syndrome. Again, a rare condition affecting either right or left side of the body with sharp midline cutoff, and it is classified with congenital epidermal nevi. However, it is functionally mosaic ichthyosis. The child syndrome is a genetic condition that is typically characterized by large patches of ichthyosiform erythroderma and limb underdevelopment or even absence of limbs. The underlying defect is known to be germline loss of function mutation in NSDHL gene. Inheritance is X-linked dominant, and condition is almost universally lethal in males. So it is mainly a female disease, and the syndrome is mainly seen in female, just like other X-linked dominant conditions. Then follicular nevus or nevus comedonicus. The nevus comedonicus is described in association with cataract, skeletal abnormalities, and neurological abnormalities. This isolated nevus comedonicus is known to be due to mutation of FGFR2 gene. So there are multiple comedones which are seen since birth or early childhood in a nevoid distribution. Then complication and comorbidities of congenital epidermal nevi. They have an increased risk of superimposed benign tumor development and risk of malignant transformation, although less. For single isolated sebaceous nevi, the risk of malignant transformation is approximately 1%. That is, syringocyst adenoma papilliferum is the commonest, whereas basal cell carcinoma occur in less than 1% and squamous cell carcinoma is very rare. HRAS mosaicism with extensive sebaceous nevi and multiple syringocyst adenoma papilliferum pose a more serious management problem. Melanoma is described in Becker nevus, then hypophosphatemic rickets, and osteomalacia is a serious complication of RAS gene mosaicism, but is also rarely seen with congenital melanocytic nevus syndrome. The neurological abnormalities which are associated with congenital epidermal nevi are the congenital structural malformation of the brain, then neurodevelopmental delay and seizures, both of which can be severe. Disease course and prognosis. At present time, all post-zygotic mosaic of congenital epidermal nevi are permanent, if not surgically removed. So these lesions should be surgically removed, otherwise they will not go. The prognosis for congenital epidermal nevi without extracutaneous involvement is excellent. Although prognosis for patients with congenital epidermal nevi syndromes remain guarded with respect to the neurological, ophthalmological, skeletal, and endocrine abnormalities, and should be assessed on individual basis. The management. Biopsy of epidermal nevi is required to make an exact diagnosis. Should the biopsy reveal epidermolytic congenital epidermal nevi, referral should be made to the clinical genetists for counseling. Similarly, congenital epidermal nevi that have inherited dimensions like child syndrome or Cowden syndrome should also trigger referral to clinical genetics and counseling with the parents. Investigation for extracutaneous abnormalities should be dictated by the clinical presentation and known association of that particular congenital epidermal nevus, for example, dental, ophthalmological, neurological, orthopedic, or metabolic assessments. So these usually are the 3 or 4 systems which are involved. Surgical excision can be suitable for small single epidermal nevi, but for more extensive lesion, it is not possible. Keratinocytic and sebaceous nevi are candidates for ablative laser treatment to reduce the thickness and hyperkeratosis of the lesions. So CO2 ablative laser can be used. A small varicose lesion have been treated successfully with cryotherapy in large series. ILVEN is treated with therapies like psoriasis, with topical calcipetrol, etanercept, oral retinoids, and the child syndrome lesions with CO2 laser and topical calcipetrol. Then treatment of extensive epidermolytic, hyperkeratotic epidermal nevi is often with systemic retinoids and topical vitamin D analogs. Then the second major group of congenital nevi is congenital melanocytic nevi. Now they are abbreviated as CMN. The congenital melanocytic nevi are benign pigmented melanocytic nevi. Prevalence at birth of a small single congenital melanocytic nevus is 1 to 2% of new birth. So this is quite a high percentage, 1 to 2%. The prevalence of multiple congenital melanocytic nevus or congenital melanocytic nevus syndrome, as defined above, is not known. Then CMN greater than 2 centimeter projected adult size is seen in 1 in 2,000 new births. So this is a little rare to see a lesion more than 2 centimeter in diameter. Then CMN syndrome usually caused by mutation of gene NRAS, and multiple CMN and CMN syndromes are therefore usually within a spectrum of mosaicism of RASopathy. A small minority of congenital melanocytic nevi are either invisible or barely visible at birth, and then become clinically apparent as otherwise typical CMN in first year of life, which are therefore termed as the tardive, slow to develop. These darken as they fully appear over a period of years. There is no sex or ethnic preference. Very rarely, full-blown phenotype of multiple congenital melanocytic nevi can coexist with neurofibromatosis type 1, which is defined in the diagnostic criteria. A full physical examination is therefore necessary in all patients of congenital melanocytic nevi, especially those with multiple CMN. Pathology. Homozygosity and compound heterozygosity of germline variants in the melanocortin-1 receptor MC1R gene was found to be more common in individuals with congenital melanocytic nevi. Then melanocytic nevi of congenital type are almost always compound nevi with both junctional and dermal component and composed of bland melanocytes that characteristically extend around the adnexal structure and often infiltrating the hair follicle and the sweat glands and the underlying muscle and fat. But there is no cytological atypia. Nodules may arise within CMN. There are almost proliferative nodules rather than melanoma. Melanoma may rarely occur in a CMN lesion. You can see the diffuse nests of benign-looking bland melanocytes occupying the papillary as well as the reticular dermis and also extending around the hair follicles and the fat. Environmental factors. Smoking during pregnancy could be associated with a small excess risk, but excluding sunbed use, medications, radiographs, alcohol, maternal infections, and anesthetics. Mothers of child born with CMN were, however, significantly more likely to have suffered a threatened miscarriage or severe nausea and vomiting or raised blood pressure than control group. So these are all chance association, no definite association is known. Clinical features. CMN are mostly brown or black, frequently heterozygous in color and texture, usually palpable with increased surface markings. Lesions are darkest at birth and usually lightens to some degree over first few years of life. For non-scalp CMN, overlying hair is often not apparent at birth and may develop in the first year. Scalp CMN often have thick, luxuriant hairs or wiry hairs at birth, which grows at a significant greater rate than the surrounding scalp hair. So the scalp hair over the overlying CMN grows more rapidly. Multiple CMN have traditionally been termed as satellite lesions, meaning locals extending from a central lesions, local seedings from the central lesions. You can see this large CMN, this again a CMN and the satellite lesions. There are two commonly arising benign proliferative lesions in a CMN, which are termed as the proliferative nodules or diffuse neuroid proliferation. The classical proliferative nodule are often present at birth. They are well circumscribed, symmetrical, round or oval, soft to firm, and have uniform color. They are usually half to few centimeters in diameter, and these nodules are usually resected relatively early if required. And they do confuse the clinician with a melanoma, and it's my experience that I was confused once such a patient came to me and I had to take biopsy and prove it that it was not a melanoma. Then another proliferative lesion is a diffuse neuroid proliferation, which develop any point during childhood and continue to grow slowly over time. It is less well defined and few centimeter to many centimeter in diameter, firm and often become pendulous when large. They are difficult to dissect as they tend to recur and sometimes quickly. Histologically, they show neuroid type differentiation of CMN. So it is a proliferative nodule of CMN, but typically it contains the neuroid type or spindle-shaped melanocytes. This is a benign proliferative nodule, and this is a neuroid proliferation in a large congenital melanocytic nevus. Nevus spilus type of CMN is only well-developed clinical variant and is comparatively rare. Then congenital melanocytic nevi are sometimes difficult to distinguish from congenital blue nevus, but the latter is usually blue-black rather than brown-black. This is the only difference. Classification of severity. The most clinically useful phenotypic measures remain the distinction between the single lesion and more than one. So the main differentiation of severity is presence of a single lesion or multiple lesion. It is therefore extremely important that patient is examined thoroughly to look for a second or subsequent small CMN, which may be relatively pale at birth. So you have to be very careful. If patient has more than one CMN, then some degree of risk of neurological and malignant complication exist. The clinical features that have been shown to have the best statistical correlation with neurological outcomes is the projected adult size. That is the projected adult size of that nevus. Many clinicians also include other details of cutaneous phenotype such as rugosity and the color of the lesion. The more rugose and more black. The neurological abnormalities. For multiple CMN, the neurological abnormalities are the commonest comorbidities. And the term neurocutaneous melanosis was initially proposed to describe this association. And the CNS abnormalities are classified into two clinically relevant groups, which are based on MRI findings. The intraparenchymal melanosis alone and others, which include all the other variants. The intraparenchymal melanosis alone is the commonest finding in association with multiple CMN. And the commonest site of intraparenchymal melanosis is the amygdala. And seizures is the most common clinical sign of temporal lobe epilepsy. Then melanoma risk. The small single lesion, the risk is relatively low and estimated as less than 1.1%. And it is now fairly well established that lifetime risk of melanoma in all sizes of CMN is 0.1 to 2%. This risk extends to as high as 10 to 14% in individuals in nevi of more than 60 centimeter diameter. So the median age of developing melanoma is approximately 7 years. There are rare reports of other malignancies arising in CMN, and most notably it is rhabdomyosarcoma. The characteristic facial feature. Children with CMN have at least 3 characteristic features. They have a wide or prominent forehead. They have hypertelorism, that is more distance between the eyeballs. Eyebrow variants, periorbital, fullness, small or short nose, narrow nasal bridge or broad nasal tip, broad or round face, full cheeks, prominent premaxilla, prominent long philtrum, and everted lower lips. So these all are the characteristic feature of children with CMN. Investigation. The diagnosis of CMN is usually a clinical one. Neurological investigations and monitoring for cutaneous and extracutaneous melanosis should always be undertaken in case of multiple CMN. Management. All children with CMN should have a clinical neurological examination after birth. Any child with clinical abnormalities should have an MRI of CNS. Children with multiple, 2 or more CMN at birth, independent of their size and site, should go for a routine MRI brain and whole spine with contrast, preferably within first 6 months of the life. If, however, MRI reveals other intracranial pathology, the child should have an urgent referral to a pediatric neurologist or a neurosurgery, depending upon the appearance. Further imaging in these cases is highly likely to be required. So neurological symptoms such as those of raised intracranial pressure or seizures should always trigger urgent MRI of whole CNS with contrast. Acute presentation at any age with neurological symptoms, as those of raised intracranial pressure or seizures, should trigger an MRI, and raised intracranial pressure in presence of normal MRI should therefore be treated as if it is due to any obstructive problem at the level of leptomeninges. Then assessment of malignant behavior can be performed using repeat MRI at intervals of few weeks until stable or clearly progressive. If clearly progressive, a biopsy of leptomeningeal tissue is indicated to assess for melanoma. Then management of new lump within a CMN. Acute presentation with a new lump in CMN, if clinically diagnosed as benign proliferative nodule, is photographed with a scale and search for lymphadenopathy. If no lymphadenopathy exists, clinical review after 4 weeks. If local lymphadenopathy is present, nodule should be removed immediately. If review at 4 weeks, the nodule is continuing to change, then definitely biopsy. If nodule is clinically unchanged after 4 weeks, continue to observe. This is in case no lymphadenopathy is seen. So a nodule at 4 weeks with no lymphadenopathy and is continually changing in size, then biopsy is indicated. If not, then only observe. It's important to stress again that melanoma is frequently overdiagnosed in patients with CMN. Where melanoma is confirmed, the outlook of patient with multiple CMN is extremely poor, and death usually occur in 6 to 12 months from diagnosis. Workup for metastasis include full body PET scan, chest X-ray, abdominal ultrasound, and MRI of CNS, if not already taken. Blood should include the lactate dehydrogenase level, LDH. Treatment of cutaneous melanoma will usually include surgery. The new chemotherapeutic agents that can target NRAS overactivity, and although these are all experimental at this stage, there is no current data to suggest that surgical removal of multiple CMN reduces the risk of malignancy. Hair can be removed most easily by shaving, which improves the overall appearance. Superficial removal techniques such as dermabrasion or curettage or laser therapy are still favored in some centers, although many large centers for CMN patients do not favor these techniques as pigment returns over time, very shortly. Then serial excision of single lesion or cosmetically prominent lesion, for example, face, can produce good results, although inevitably will leave a scar. And some centers favor the large-scale removal using balloon skin expander. So balloon is inserted into the dermis, deep into the dermis, which expands the skin, and then the lesion is gradually excised. Congenital Spitz nevus. Congenital Spitz nevus is rare, with no reliable estimates of prevalence at birth, and is important that it rarely mimics melanoma. And diagnosis is therefore often made after excisional biopsy. The spitzoid change is also described within a congenital melanocytic nevus. The incidence of malignant transformation in congenital lesion is not known. Agglutinated or eruptive Spitz nevus can rarely present at birth. Then congenital blue nevus. Congenital blue nevus are rare and can either be of common cellular or epithelioid blue nevus subtypes. The congenital common blue nevus exhibit the same clinical and histological features as that of their acquired counterparts. The only difference is their early presentation. Where the clinical appearance is typical, resection is not required for medical reasons. Congenital cellular blue nevus, on the other hand, frequently significantly larger than their acquired counterpart and most frequently seen on the scalp. This variant is described in association with various underlying scalp and neurological defects and with malignant transformation. So such a large lesion need to be excised. This is a normal congenital blue nevus, and this is how it will look like as ribbon-like pigmented melanocytes in the dermis. Congenital Naevi spilus. The congenital Naevi spilus or speckled lentiginous nevi are pigmented lesions with a caphole macular background and superimposed with more darkly pigmented areas or speckles. The superimposed pigmented areas are usually small, a few millimeters in diameter at most. Some lesions are entirely macular, and some have papular or less uniform speckles. So the Naevi spilus has two types of pigmented lesions. Histological Naevi spilus is a lentigo simplex, and the background, the caphole macular background, with superimposed benign junctional or compound melanocytic nevi. So background is of lentigo simplex and superimposed by junctional or compound nevi. Naevi spilus generally single, but size varies from few to centimeter to larger, involving the whole limb or in a segmental distribution. Large lesions can form part of the Phakomatosis pigmentokeratotica. This is a speckled nevus. You can see the background of caphole macular pigmentation, and on top of that, there are a few small junctional nevi. Then we have come to the third part of our talk, that is the congenital connective tissue nevi. The congenital connective tissue nevi are benign cutaneous hematomas of the connective tissue components present at birth. They are clinically heterogeneous group of hematomas named by the predominant cell type on histology, therefore usually require a biopsy for accurate diagnosis. Congenital connective tissue nevi as a group are rare at birth. There is no sex predilection, no difference in ethnic groups. The clinical features. By definition, the lesions are present at birth, although average age of presentation or appearance of any connective tissue nevus is 2 years. They can be single or multiple and associated with extracutaneous features. And they sometimes continue to grow or develop with adjacent new lesions, particularly the plantar collagenomas in Proteus syndrome and elastomas in Buschke-Ollendorff syndrome. Then congenital collagenomas. The congenital collagenomas are soft, firm, skin-colored, brownish or yellowish nodules or plaques. This is in contrast to eruptive collagenomas, an acquired disease of multiple lesions appearing after puberty. The collagenomas are associated with Proteus syndrome, occurring characteristically on the sole and feet in first few years of life and are cerebriform in appearance. You can see them. This is a collagenoma with proliferation of collagen bundles in a nodular fashion, but non-encapsulated. Then congenital elastomas. These are firm skin-colored or creamy yellowish papules or nodules with diameter ranging from few millimeters to several centimeters to a centimeter, They are not very big, often coalesce to form plaques and clusters. In Buschke-Ollendorff syndrome, they classically present in group or plaques on lower abdomen, trunk, arms, and buttocks, the elastomas. Then congenital lipomas are present as localized, skin-colored, soft proliferations with indistinct edges. The McCune-Albright baby phenotype is associated with both fat nevus and diffuse smooth muscle hematomas. In this phenotype, the infant has generalized thickening of skin with pronounced folds. The nevus siloliparus is a rare entity characterized by aberrant hair follicle development and prominent fat deposition, which present as smooth skin-colored or yellowish, flat or slightly raised lesions on the scalp. So this is confused with sebaceous nevus. So McCune-Albright baby. Association, syndromes, and genetics. Elastomas are presenting feature of Buschke-Ollendorff syndrome, which is an autosomal dominant disorder, which is caused by mutation of LEMD3 gene. And we have to look for osteopoikilosis. Then plantar collagenomas are seen in Proteus syndrome, and there is PIK3CA overgrowth syndrome. Then mucinous nevi are described with lysosomal storage disease like Hunter syndrome, which is an X-linked recessive condition due to germline mutation in IDS gene. Fibrous connective tissue nevi are frequent features of tuberous sclerosis, which is an autosomal dominant hematomatous syndrome caused by mutation of TSC1 and TSC2 genes. Congenital lipomas in pediatric dermatology lies in association with lumbosacral lesions and underlying spinal defects. They also form part of encephalocraniocutaneous lipomatosis, for which ophthalmological and neurological investigations are required. So associations are common. Investigation. Histopathological examination of full thickness skin biopsy is must for accurate diagnosis of connective tissue nevi, with adjacent normal skin being helpful for comparison of the subtle dermal changes. Management. Family history, examination, and follow-up for any associated non-cutaneous or syndromic features are important. In absence of these, single lesions can be followed up until deemed to be isolated and stable. Then observation is stopped. The nevoid entities, which are also called as the unclassifiable nevi. So Becker nevus is one of the type of nevus which can neither be classified in the congenital epidermal nevi variety or pigmented nevi variety. The Becker nevi or Becker melanosis is relatively a common hyperpigmented, generally non-linear lesion with incidence of around 0.25% and common in male than in female. Majority of lesions appear in first 2 decades. So it's not present at birth and usually develop at puberty. It is frequently but not always hypertrichotic, that is, hairs are prominent, and it is the commonest on the upper trunk. It shows feature of lentiginous melanocytic hyperplasia, features of epidermal hyperplasia, and smooth muscle hyperplasia. So mild changes are seen in all the 3 components. Becker nevus is not uncommonly associated with extracutaneous abnormalities. Then it is termed as the Becker nevus syndrome. And these include aplasia or hypoplasia of underlying breast tissue, or pectoralis major muscle, or sometimes shoulder muscles. Lipoatrophy, ipsilateral limb growth disturbance, and supranumerary nipples and scoliosis. This is a classical Becker's nevus occurring on one side of the chest. Then Angora hair nevus. Its Angora hair nevus is extremely rare, hypertrichotic nevus with increased pigmentation in the basal layer, where the hypertrichosis has a hypopigmented and fine texture. So hairs are hypopigmented and fine in texture, and they are described in linear or non-linear fashion, and it is associated with extracutaneous abnormalities. And this Angora hair nevus is usually confused as a Becker nevus with a Becker nevus, and usually it is not that pigmented, and the hairs are also fine. Then linear atrophoderma of Mollin. This entity describes an acquired hyperpigmented atrophy of subcutaneous tissue in the Blaschkoid linear distribution. So it is actually an acquired hyperpigmented atrophy of subcutaneous tissue, generally appear in first 2 decades of life and stabilize after its initial development, and most commonly lesions are seen on trunk and is unilateral. This is confused with morphia. So it is not inflammatory and does not progress. Then other linear lesions include lichen striatus and linear morphia or scleroderma, which are described elsewhere. The linear manifestation of some X-linked skin diseases, the classical example is that of incontinentia pigmenti, which is described elsewhere in other topics, in other chapter. Then linear manifestations of generalized skin disease. These occur either as a single or linear lesions or linear component of a generalized disease. This hypothesis has so far been proved for linear Hailey disease and linear Darier's disease. Then Blaschkoy linear areas of conditions where the genetic basis is not fully understood include the linear atopic eczema, linear psoriasis, linear granuloma annulare, linear lichen planus, and linear pemphigus vulgaris. A term, Blaschkitis, is used for inflammatory Blaschko-linear lesions. They are not, as a rule, congenital. Other developmental abnormalities include aplasia cutis congenita. The aplasia cutis congenita is a descriptive term that encompasses various different abnormalities which have in common a congenital localized skin defect. It's a large classification of aplasia cutaneous congenita. The most commonly, in more than 85% of the cases, there is a single isolated lesions near the vertex of the scalp. So this is the most typical presentation of aplasia cutis congenita. ACC can involve any area of the skin and is associated with underlying defects of muscle, bone, or even dura, and can be a feature of many different genetic diseases. If further investigation is warranted, MRI of brain is the most appropriate investigation. At birth, the lesions can either be healed with scarring, often with a thin parchment-like appearance, or they can be open with varying level of ulceration. A ring of hairs around the defect is called as the hair collar sign and is thought to be associated with increased risk of underlying defect. Prognosis for single superficial lesion is excellent, resulting in cosmetic defect only. However, in cases of underlying tissue defect, there is appreciable mortality, particularly if CNS is involved. The prognosis for syndromic forms varies with underlying genetic abnormalities. It can be seen with chromosomal abnormalities, particularly trisomy 13, which is the Patau syndrome, or 4p16.3 deletion. Other recent identified genetic causes of ACC are mutation of BMS and COX7B gene. The histopathological features of typical ACC include flattened epidermis with characteristic features of underlying marked dermal fibrosis, within which there is complete absence of normal adnexal structures. Then congenital smooth muscle hamartoma. The smooth muscle hamartomas are benign collections of mature smooth muscle fibers within the dermis. Clinically, they are solitary, soft, skin-colored or slightly pink brown, hairless lesions, usually few centimeters in diameter with indistinct edges. Characteristically, they demonstrate induration or worm-like fasciculations when the lesions are rubbed, and this is called as the pseudo-Darrier sign, with raising of overlying thin hairs, goose pimple-like. Once established, they are static in behavior, and malignant transformation is not reported feature, and resection is not medically required. On histopathology, it's poorly circumscribed, non-encapsulated lesion in the dermis with numerous well-defined bundles of smooth muscles which are characteristically oriented in various directions. This is a clinical look of a smooth muscle hamartoma with blonde hairs. Striated muscle hamartoma is an uncommon congenital lesion and arising at head and neck region with the propensity for chin area. Clinically, it is soft and polypoid. Histologically show benign striated muscle fibers within the dermis or subcutis with or without hamartomatous collection of other cutaneous components. These lesions can be isolated or associated with extracutaneous abnormalities. Then McCune-Albright syndrome. The McCune-Albright syndrome is the classical triad of Caffole macules, polyostotic fibrous dysplasia, bone defect, and autonomously hyperfunctioning endocrinopathies, and at least 2 of the 3 features should be present. Now describing each lesion. The Caffole macule are large, present at birth, or appear early in first decade, segmental and have irregular edges. So large Caffole macules. Oral pigmentation can arise later in childhood or in adult life. Then about the bony involvement. Bony involvement is seen with pathological fractures, with visible deformities, and bone and joint pain. And the endocrine abnormalities, the most common is the gonadotropin-independent precocious puberty, which is seen earlier in girls than boys. And other defects include the growth hormone excess, hyperthyroidism, Cushing syndrome, and hyperparathyroidism. So all kind of excesses: growth hormone, thyroid hormone, cortisone, and parathyroid hormone. Treatment instigated as appropriate. As appropriate endocrine abnormality or the bone defect is seen. Sturge Weber syndrome. The association of extensive facial and truncal port wine stain with contralateral focal seizures thought to be due to ipsilateral abnormality on the surface of brain and ipsilateral intraocular vascular malformation presenting with glaucoma. So the port wine stain on one side of the face involved the brain of the same side of the face as well as the eyes, but lead to contralateral seizures, focal seizures. The neurological complications of these vascular malformations, including seizures, neurodevelopmental delays, headache, stroke-like episodes, behavioral problems, hemiparesis, contralateral, postnatal asymmetric overgrowth of face or limbs. A strong association between lesions affecting the forehead, defined as areas above the line joining the outer canthus of eyes to the top of ipsilateral ear helix, including upper eyelid, and the Sturge Weber syndrome. The Sturge Weber syndrome. So it is characterized by tram-line classification in the brain, the port wine stain on nevus flammus, then vascular headaches and glaucoma. This is a patient of Sturge Weber syndrome. Guidelines have been proposed that urgent ophthalmological investigation is required for the infants with port wine stain and targeted for those with lesions involving any part of the forehead, as well as MRI of CNS is done, and glaucoma can be present from birth. So recent guidelines suggest MRI within the first 3 months of life in high-risk group and repeat scanning at later stage if clinical suspicion, but the first scan was clear. This is important because prophylactic use of oral therapy in infants with cerebral involvement reduce the venous stasis-induced cerebral atrophy and calcification. And there is ongoing debate regarding the prophylactic anticonvulsants in presence of radiological abnormalities. Then the last condition to be discussed is Phakomatosis pigmentovascularis. Phakomatosis pigmentovascularis is a descriptive term currently applied to group of phenotypes that are unified by coexistence of different pigmentary and vascular cutaneous lesions. In practice, the term is originally used to describe a combination of capillary malformation, that is port wine stain or nevus flammus, with dermal melanocytosis or Mongolian blue spots. So combination of vascular lesion and Mongolian spot. The known association of Phakomatosis pigmentovascularis are the nevus anemicus and scleral or intraocular melanocytosis. And this is not evident, may not be evident without dilatation and slit lamp examination of eye. Therefore, an ophthalmological review must be arranged in such patients. Glaucoma, for which an urgent referral to ophthalmology should be made as soon as the diagnosis is suspected. Intracerebral vascular malformation, for which we should suggest MRI of brain, should be performed within first few months of life. Clinically, these lesions can be accompanied by macrocephaly, developmental delay, and seizures. Potentially prophylactic medications are given to reduce the effect of venous stasis and underlying cortical atrophy. Overgrowth with either full hypertrophy or localized asymmetry of the face or limbs has led to the concurrent diagnosis of Phakomatosis pigmentovascularis and Klippert-Tononi syndrome. Melanoma of choroid and conjunctiva and melanocytoma of optic disc are all described. So this brings to the end of this talk. I hope this lecture was a good revision, and hope to see you next time with another edition of my lecture. Thank you, goodbye, and have a good day.